Oh, hi everyone. Great to have you here again for what is the 37th session of this collaborative series by Heart Foundation, ACRA, TRACS and Rural Health West. So thank you for attending. I'll start today by acknowledging the traditional owners of the lands where I am, and that's the Whadjuk people of the Noongar Nation. And I pay my respects to their elders past, present and emerging, and I acknowledge their courage, resilience and their gentle spirits. I also acknowledge any Aboriginal people present in the room today. So today I have with me Andrew Maiorana, Professor Andrew Maiorana, who many of you I'm sure know. Andrew is the head of exercise physiology at Fiona Stanley Hospital, and also he is a professor at Curtin University at the School of Allied Health. So today I encourage you to put any comments and any questions in the chat function, and we will monitor that as we go along, and Andrew will certainly address your questions and comments at the end. So I also welcome people from all over WACS, from Derby, Broome, Tom Price, those in Metro, from Fiona Stanley, from Royal Perth. We have people from Bunbury, Rockingham, the Central West and Northam, and we even have a couple of people from New South Wales. So welcome all, and I'll pass you all on to Andrew to start. Thank you, Andrew.
Thank you very much, Helen, for the kind introduction. I'd also like to acknowledge that I'm joining you from the land of the Whadjuk Noongar people, and also to pay my respects to Aboriginal people all over Australia. So yeah, look, I'm going to talk a little bit about managing at a distance and using telehealth to deliver exercise prescription, predominantly in patients with cardiovascular disease, but I'll also talk a little bit about some work that's been done nationally in Australia that has included cardiac rehab environments, but also other forms of exercise delivery. So, you know, telehealth has been on the agenda for quite some time, but it was really the onset of COVID-19 that really encouraged us to consider telehealth more actively in our clinical practice. And I'll talk a bit today about the clinical practice in cardiac rehabilitation at Fiona Stanley Hospital and how we've utilised telehealth and our experiences with that. So as we're all acutely aware, COVID-19 has had a massive impact on the way that we work. You know, there were lockdowns when services literally ceased overnight, and that was very much the case for our service here at Fiona Stanley Hospital. But even between lockdowns, we had reductions in outpatient services due to physical restrictions on having multiple people in a room, and physical distancing as part of that. People required to isolate, so not able to come to services even when they're available. And you know, these might have been people who you know, were close contacts, so didn't actually have COVID-19, but you know, perhaps had you know, walked into a supermarket at the wrong time and had been designated a close contact according to the rules at the time, so weren't able to come to services that were available. We've also found that, you know, that some patients have been really reticent to attend in person within an outpatient clinic at Fiona Stanley Hospital. You know, being quite nervous about coming into the hospital environment, perhaps catching public transport to get here. So all of these reasons have really led us to explore how we can better manage patients with their exercise prescription and their cardiac rehabilitation as a whole at a distance. So managing patients at a distance certainly isn't new. COVID-19 has sort of brought it to the fore. But we've known for a long time that patients living in rural settings tend to attend less cardiac rehab, and that can be an issue of access. Those patients who live at least 60 minutes from a cardiac rehab program are the ones who are least likely to attend, and I guess that makes sense. And looking at the map of Australia, the little red heart shapes are cardiac rehab programs that had registered with the National Directory. So I apologise if someone runs a program that's not listed there. But you can see the majority of programs are on the eastern seaboard of Australia, the southwest corner of WA. But there's a lot of territory through WA, outback South Australia and the Northern Territory and the interior of New South Wales and Queensland, where people don't necessarily have ready access or close access to cardiac rehab programs. So it's quite well acknowledged that more flexible options are required to provide cardiac rehab for people who don't live in major metropolitan areas, major regional centres. So there've been a number of studies that have looked at telehealth delivered cardiac rehabilitation. I'm just going to touch on a couple here and then sort of move more to some practical discussion around telehealth. But probably the first smartphone-based cardiac rehab program was published in 2014. The study actually ran from about 2009. So it was data that was collected sometime before 2014. And it was a project that randomised people to either traditional cardiac rehab or a remotely delivered cardiac rehab program via a smartphone. And there was an exercise component to this in that participants were given encouragement around their exercise routine. But I guess it wasn't specifically designed as a cardiac rehab exercise intervention. It was very much a holistic intervention. And this study was the precedent for the CardiHab program that's available in the current time and being rolled out quite widely. So the study, as I said, was to investigate smartphone-based home service delivery for cardiac rehab versus a more traditional approach to cardiac rehab where patients receive support face-to-face. So it was in post-MI patients. And what they found was that uptake was higher in the smartphone-based program. So 80% of the participants who were randomised to that program took it up, as against 60% of the participants to the traditional cardiac rehab. But they're also more likely to complete the program. So 48 out of 60 participants completed the remotely delivered program, whereas only 28 out of 60 completed the traditional cardiac rehab program. They also reported some fairly typical outcome measures from cardiac rehab, and by and large they found that the effectiveness of the remotely delivered cardiac rehab was fairly consistent with what was observed during the traditional approach to cardiac rehab. So 6-minute walk tests, distance as a measure of functional capacity improved over 6 weeks and was maintained at 6 months, and the improvement was perhaps slightly higher if you look at the chart in the traditional cardiac rehab program, but there wasn't a significant difference between the two groups. They also found sort of similar responses for LDL and HDL across both programs, and similar responses in terms of quality of life and depression scores. So I'm just gonna present very briefly a project that we did a few years ago now, just to, I guess, highlight how telehealth-based cardiac rehab and exercise provision can actually be provided at great distances. We undertook a study called the SMART CRSP study. It was one of my PhD students led this work, where we ran a cardiac rehab program for patients in Shanghai from Perth. So my PhD student, Tashi, was previously a cardiologist in Shanghai, but based here in Australia doing his PhD. We used the social media platform WeChat, which is really popular in China. It's kind of a bit like Facebook on steroids, I guess. Like, it uses a combination of the functionality of Facebook and WhatsApp and various other apps, banking apps and so forth. So it really incorporates many aspects of life, day-to-day Chinese life, and you can sort of get a bit of a sense of that from just looking at the all of the different components that are on the screen. So what we did was we used WeChat as a way of providing education and also monitoring for patients following an acute coronary syndrome in Shanghai, in China. And it was, again, a multimodal, multifactorial cardiac rehab program with health education, support for medication adherence, some remote monitoring of blood pressure and physical activity, information about diet and weight control. Part of what we did was we sent little pictures with health education related to the pictures via the smartphone to reinforce healthy lifestyle behaviours. But we also did some remote monitoring, and we monitored blood pressure with the device that you see on the screen, but also monitored physical activity. And patients were encouraged to try to achieve that goal of 10,000 steps a day, at least working up to that over time. And you can see that that some of the patients were achieving that or falling just short of that, and they were getting reinforcement of the good work that they were doing with their physical activity, and also for patients who were much below the physical activity sort of goals that we were setting them, they were given additional education and encouragement around achieving those goals. You can see that at the top there, the little cartoon figure of the doctor is actually Tashi, who was running the program. So often his step count was lower than many of the patients, which was something that the patients would often feed back to him about. So it sort of created a nice little network amongst people. So in terms of the results from the CRSP study, so this was a comparison of that telehealth delivered cardiac rehab versus usual care, and usual care in this setting was patients who weren't getting any cardiac rehab, so they had no cardiac rehab running in their hospital. And we saw an improvement in 6-minute walk test distance with the group that was undertaking the trial compared to the control group. They had a better knowledge of coronary heart disease. Importantly, though, their adherence to medication was much better, and we were certainly reinforcing that over time. Whereas in the control group, their adherence over time was dropping off. Certainly dropped off in the first 8 weeks following their event. And the other thing that we saw was that systolic blood pressure was much lower in the group that received the intervention, and it was maintained at a lower level over the 6 months of follow-up. And this is probably partially due to being more adherent with their medication, but I suspect it's also, excuse me. Sorry, just someone coming in the door. Apologies about that. So yeah, so systolic blood pressure was probably reflecting in part more adherence with core cardiac medications, but possibly also the improvements that we were seeing in fitness with 6-minute walk test distance and general lifestyle improvements. Okay, so sort of moving to our experiences at Fiona Stanley Hospital, one of the really important aspects of a cardiac rehab program is functional evaluation at the outset of a program for patients, so that we can evaluate their exercise tolerance and use that to guide the exercise prescription. And there are a number of ways that can be done. The 6-minute walk test is the most commonly used test in Australian cardiac rehab. We also use cardiopulmonary exercise testing in some of our heart failure patients, because we use it as a surveillance measure in our patient cohort for clinical reasons, because it's a very strong prognostic indicator in patients with heart failure. So that's also very useful for us in terms of prescribing exercise. And then some centres use exercise stress tests. Now, this is very much the American model of assessing people before cardiac rehab, but my experience of the Australian context is that very few centres mandate exercise stress testing before cardiac rehab. But all of these forms of physical or functional assessment are really useful in evaluating the patient, so that you can tailor the cardiac rehab exercise program to the individual. So the first challenge that we had when we moved to a situation where we were having lockdowns and we couldn't get patients into the hospital environment, into an outpatient environment, was how do we evaluate these patients from a functional perspective when we can't see them face to face, where they're not in in our room with us, or then we're not able to watch them exercising and evaluate their response to exercise with heart rate and blood pressure and ratings of perceived exertion. So we considered that, and we felt that we still wanted to be able to to do some sort of functional evaluation on the individuals who we were going to be prescribing exercise for, but many of whom we'd never met before. We wanted to do that safely. We wanted to use a measure that was a valid assessment of their functional capacity, that was reliable and was meaningful. So we went through a bit of a process of looking at different ways of evaluating functional capacity, and we considered some of the questionnaires that are available. So probably the most widely used questionnaire for evaluating functional capacity is the Duke Activity Status Index, or the DASI. So this was originally designed as a self-administered assessment tool to evaluate functional capacity in patients with cardiovascular disease. It has 12 questions related to the ability to perform a variety of common activities. And it has a moderate correlation with VO2 peak, VO2 peak being the gold standard for measuring someone's aerobic fitness. But the limitation of the DASI for our needs is that it doesn't provide direct evaluation of exercise tolerance. Okay, it's very general in the type of activities that it assesses, and while that's useful, for us, it didn't give us the same valuable information that you might get if you're watching someone do some exercise, watching them do a 6-minute walk test, and evaluating how they manage with that. We also looked at a similar questionnaire, the Clinimex Aerobic Fitness Questionnaire, which is sort of based on the same principle as the DASI. It describes physical activities with corresponding MET values, ranging from very low activities, essentially lying in bed, through to quite intense activities, up to 21 METs, which is something like running a half marathon. It also has a two-step approach, which allows refining the estimate of maximal exercise capacity beyond what's achievable with the DASI. And because of this, its association with functional capacity is much stronger. So a correlation with performance on a cardiopulmonary exercise test from some research that's been done is around 0.8, which is really, quite impressive. But again, that same limitation was there, that it doesn't give you the ability to observe a patient exercising, to measure their physiological response, and to flag any issues that they may have during exercise before we prescribed an exercise program. So digging a little bit deeper, and this was really timely because it was sort of published not long after we were sort of going through this process of trying to determine how best to evaluate functional capacity. A systematic review was published by a group out of Queensland that looked at different forms of remote functional assessment in patients with cardiac conditions. And they found 5 studies that had used 6-minute walk tests in a home environment, and 1 study that had used a timed up and go test as a way of evaluating functional capacity. There were no studies that used step tests, sit to stand test, or shuttle tests that they reported. So the 6-minute walk test, interestingly, was administered often over a very short distance, so quite different to the standard 30-metre track in a couple of the studies, just using a 5-metre rope at home. One study used a 30-metre track. We considered using the 6-minute walk test at home, but we actually found that it wasn't practical for a lot of people to do a 6-minute walk test in their home environment. The other thing that we were really keen to do is to use a test where we could observe the patient the whole time rather than having them walking out of view. So we considered the 6-minute walk test. We also considered a Chester step test, which is a multi-stage submaximal test, where patients step up and down on a box step, or they can use just a normal step at home. But we again weighed that up and elected that it wasn't going to work ideally for our needs. We were dealing with some patients who were relatively frail, and other people who didn't have a step at home or didn't have a step in a location that we could set up their camera and observe them. So we opted out of that, and then ultimately settled on a sit to stand test for evaluating functional capacity. We toyed with whether it should be a 30-second or a 1-minute sit to stand test, and looking at the literature, there was much more extensive literature around the reliability of the 1-minute sit to stand. It's been used quite extensively in pulmonary cohorts, but much less so in cardiac patients. It's sensitive to change, so it has an established minimally clinically important difference, and has moderate correlation with 6-minute walk test distance, which we found interesting because when we first started considering the sit to stand, we thought, well, it's possibly more of a test of muscle strength, of thigh muscle strength for some people, especially older, more frail people. But relatively good correlation with 6-minute walk test distance. And for that reason, we decided to go ahead with the sit to stand test as our way of assessing people as they entered into a telehealth program. So these again are people who are not able to come into a hospital environment. Just in terms of the practical implication of the sit to stand test, the equipment that people need is minimal. So a stable armless chair, so a dining chair is fine for this, sort of an average height. but importantly to place it against a wall so that the person doing the test isn't at risk of sort of going up and down and pushing the seat back and then going down again and missing the seat. We wanted to do the test so that we could observe the patient doing the test. So having a camera from a smartphone or some other form of device that allowed the seat to be in view was what we were trying to achieve with patients. And we also encourage them to get their family members involved if possible, like filming them as they were doing it. So the instructions are pretty simple, and you can see an image here of someone doing a sit to stand test with the chair against a wall. So when I say go, I want you to repeatedly stand all the way up and sit down as fast as you can without delay. And to continue that for up to a minute or until you feel you need to have a rest. So with our process, we were trying to be consistent with what we would do in a hospital-based clinic environment. So we would speak to the patients before to determine their clinical stability, identify any recent change in symptoms. Patients with heart failure, like we do in an outpatient clinic, we would get them to weigh themselves every time they came to a session. So we would get the patient to weigh themselves and get any feedback on whether there's been any rapid weight fluctuation over recent times. Some patients had home blood pressure monitors, so we would get them to take their blood pressure if they had that, and also to take their resting pulse or heart rate. And most of the patients were quite comfortable palpating their pulse. And then at the end of the test, in addition to the number of sit to stands that we recorded, we would also do a post-test assessment, again consistent with what we would do after a 6-minute walk test, looking at heart rate, blood pressure response if BP was available, and rating of perceived exertion using the Borg scale, as well as any symptoms that the person experienced. So we found that this was a relatively useful way of just doing a preliminary evaluation of a person's exercise tolerance, and a useful way of guiding us in the preliminary exercise sessions that we were delivering via telehealth. So we at Fiona Stanley moved fairly quickly to a mixed model of delivery of cardiac rehab. So we certainly had a period of time during lockdowns where the cardiac gym was closed completely, certainly an extended period during that first lockdown in 2020. But more recently this year, we've had some patients coming in to face-to-face, but keeping the numbers right down, and only our highest complexity patients. And this has been with the strong backing of our medical referrers. So these are typically patients who are waitlisted for cardiac transplant, patients with left ventricular assist devices, or early post-cardiac transplant or implantation with an LVAD. So with those patients, any of the transplant patients have been until recently coming in just to one-on-one sessions, not mixing with other patients when they've been coming in. For other patients, we've had sessions with 2 patients, but maintaining physical distancing. But patients all need to have RATs before they come. Before every session, they need to get a RAT, and if they've got any symptoms, then they don't come in. But in addition to that, because it's just been a fairly small proportion of our patients, we've had telehealth video delivered cardiac rehab sessions, sort of based on what I've just discussed about that functional assessment, and then continuing on with telehealth delivered exercise sessions, as well as some phone call check-in for patients. So some patients were quite happy and preferred to be given a home exercise program, but didn't necessarily want to have that video interaction with staff. So for those patients, we're just doing a phone call check-in once a week or once every 2 weeks for some patients. Others felt much more comfortable with having those telehealth sessions and felt that it was going to be better for their motivation to exercise. So the way that we've approached those telehealth sessions is use lots of the principles that you might apply with home exercise delivery, but incorporating that into these sessions where our staff join the patient remotely in supporting their exercise program. We try to complement those telehealth sessions with independent sessions where the patient does some home-based exercise, and that's fairly typical of what we would prescribe generally for our patients. We do a pre-exercise evaluation, as I described for the functional evaluation or the functional assessment. So checking the patient's taken their routine meds, screening for change in symptoms, reviewing weights in our heart failure patients, and then checking resting heart rate and blood pressure if a patient has a monitor. Documenting the session performance of the patient, again, so making sure that we have a good database of their exercise performance, their exercise duration, intensity. Again, we use rating of perceived exertion charts. We can use those by video. And really, one of the values of having that remote access to the patient via telehealth is being able to guide exercise technique, and that's been really useful, especially in patients early in their programs who haven't historically had a history with regular exercise. So teaching them about their technique that would be very difficult to do just over the phone without getting feedback from the patients. And try to utilise exercise that can be performed in view of the video, so that the patient's not moving a lot out of the view of the video while they're exercising. So chair-based exercise, marching on the spot, using resistance exercises with various dumbbells, bands, objects from around the house if people didn't have access to dumbbells, filling up a milk container with water or sand. And then body weight exercises as well. Now, most of the sessions that we've run have either been one-on-one, one-on-one, or just with a very small group of patients. We found that any more than about 3 makes it really hard to manage. Possibly with more experienced participants and a different cohort of participants, then that might be something that you could expand with a larger number of patients. And we have accessed some exercise apps like Physio Tools and various other apps like that to provide some additional support to patients. Another thing that I've been involved in over the last couple of years is a survey that's part of a research program being conducted by Exercise and Sports Science Australia, looking at telehealth delivered exercise physiology programs around Australia. And this has included cardiac rehab programs, but it's also included programs outside of cardiac rehab. And I'm just going to give you a bit of feedback on what we've observed through these surveys and some interviews that we've done with people who've been involved in exercise physiology programs historically, but then were sort of given the option of transitioning to a telehealth program when COVID came about. So we interviewed both clinicians and also clients or patients. And what we found with the clinicians is some adopted telehealth really quickly, whereas others were a bit reticent to adopt telehealth. So just these are in the top table here. These are some of the reasons for not offering telehealth across 80 different practices around Australia. So some people were concerned around the physical or cognitive capacity of their clients. So about 40% of the services that we surveyed opted not to do telehealth because of these reasons. And this was fairly early in the piece. This was in 2020. Concerns about client safety in about 30% of cases, access to a reliable platform, so a telehealth platform, client language and cultural barriers in a few cases. Some people just ceased all their services. Cost of setup for the client was also mentioned in a couple of cases. Okay, and some of the additional resources that were used by people included, and so these were those practices that took on telehealth: text message reminders, follow-up phone calls, written instructions, apps for a smartphone or tablet, educational material, videos, provision and purchase of equipment or devices, logbooks and diaries, and then using different websites, diagrams or booklets. So I think this just highlights that, that telehealth can be delivered in lots of different ways. That means something different to different people. So there are lots of different components of how telehealth can be delivered. This aspect of the survey just explored some of the reasons why people didn't take up the telehealth that was offered to them, or they didn't complete the telehealth. And this is really quite consistent with our experience at Fiona Stanley Hospital, that that some people weren't really keen to even give it a go, and they'd prefer just to do their own thing and get the odd phone call rather than having a more formal telehealth video conferencing arrangement. And some people tried it and it didn't particularly work for them, whereas others thought it was great. But some of the reasons for not taking it on across this national survey was the client preferred not to do telehealth. They wanted to stick to a traditional exercise approach, felt that it wasn't suited to their physical abilities. Either the client or the provider wasn't able to access a reliable platform. The client or the clinician were concerned about the costs of setup. Again, cultural and language barriers, and client safety was also an issue. And that was certainly something that we considered and probably procrastinated over a little bit, especially with some of our more complex and potentially higher risk patients who have severe heart failure. So non-completion, similar types of responses. Some people dropped out because they didn't like it, or they didn't have confidence in telehealth. They felt that they didn't really understand it, or found that it was perhaps difficult to engage with. So it's something that, in our experiences, worked well for some people, but not so well for others. So these are some of the comments that people made when we interviewed them about telehealth, and these are a couple of enablers or positive feedback around telehealth. And it was really the most positive thing was around about the access. So one participant said that it's really accessible for me, being able to do my exercise in the morning, at home in a space that I've set aside, is much better, and it rules out the need to travel. Second participant's response was along the same lines. The best thing is I don't have to travel anywhere. So with telehealth, had more regular attendance. I'm doing 3 sessions a week via telehealth, whereas if I was going in person, I'd be lucky to do 1 session. And then other people sort of highlighted what some of the barriers were. One person said that because I'm lazy, basically, using telehealth, I need someone really cracking the whip, and they felt that they got that more in a face-to-face session. And again, along a similar theme, that obviously you're motivated because someone's kicking your butt. And again, that was related to being in a gym-based environment with with an exercise instructor. Some tech issues had put people off, although most people found that they were able to work through the tech issues if they persevered with those. But certainly, in our experience, if there were tech issues, especially for people who are a little bit apprehensive about taking on the telehealth and perhaps had some reservations around the tech initially, it didn't take them much to say, look, this is just a bit too much for me, and I'm going to give it a miss. Probably the biggest comment that we've had, anecdotally at Fiona Stanley Hospital, is not having access to the equipment that's available in a gym-based program, and that was fairly consistent with what we saw in this national survey. So some of the comments are that, sorry, you've lost me. Some of the comments were that they've got different machines, different kinds of setups, and I don't necessarily have the space and the finances at home to get all of that equipment. And someone else saying that I'm really limited with the equipment that I have at home, and that they would much prefer to be coming to a gym-based exercise program where much more equipment's available and they can get more out of their exercise sessions. Supervision and feedback was felt to be much better during face-to-face sessions based on people's response. On using telehealth, trying to get it right took more time. That was a possible negative. What I found very important was that they could gauge your physical capabilities in person much better than on telehealth. Also, they could correct the pose of the particular exercise that you're performing. And it was that fine tuning that I think is so advantageous about face-to-face. And then the other comment was around the social engagement that people experience during face-to-face sessions. And we've been aware for a long time that one of the benefits of group-based exercise is actually the social support that people get in that environment, whether it's from the staff or from other participants in the program. So a couple of comments here. I'll just go to the second one. I think face-to-face is just more personal. The staff to get to know you and vice versa, and there's possibly more interaction that way than with telehealth. And I think there's a nice sociality about it too. I really enjoyed walking in, chatting to the admin person there, having a chat with previous instructors if I had those. And I think many of you who have been involved in group-based exercise programs will recognise these benefits that people report about coming into a group-based exercise environment. And that doesn't work for everyone. I think in our experience, we've got a lot of patients who are really keen to come back into the gym. Some of our longer-term patients who are part of our advanced heart failure program are really chomping at the bit to come back into the gym. But they're probably patients that self-select a little bit because they're the ones who've been compliant with gym-based exercise in the past, whereas people that haven't been in a gym-based exercise program are potentially the ones who might be keener on a telehealth approach, or it might just be more convenient for them. So we found that telehealth wasn't without challenges, and I'm just going to run through some of those challenges. It's a fairly long list. Still, that challenge of not meeting someone in the flesh and sitting down with them and having a conversation at the outset of a program, getting them to do a functional evaluation by way of a 6-minute walk test or something else, and watching their response to that. We've as a group have discussed this quite a lot, and that's one of the really important aspects of being able to see someone face to face, especially at the outset of a program. you know, there are the tech issues, and we've had tech issues derail sessions quite commonly. We sort of resolved those as we got a bit more experience with the platform, and we're able to troubleshoot issues. But it can be a problem for some people, and it doesn't take much to put people off if there are tech issues involved. Connectivity in some places continues to be an issue, both in the metropolitan area, but also especially in regional and remote locations. And that's one of the drawbacks of using telehealth, which is ideally suited to supporting people who live a long way from a cardiac rehab program. Sometimes the connectivity issues can really be a barrier. Sometimes the home environment isn't particularly well suited to exercise. It might be the physical layout. We've had people's dogs barking at them, and all sorts of things. Someone arriving back home, or a random knock at the door. So there are a few little issues that one needs to work through. Some people just found that they didn't like the video coming into their house, that they found having a video in their house intrusive, which was quite interesting. They just weren't particularly comfortable with that aspect of telehealth. Or we get people to set up with their exercise, get the video to be filming them in a given spot, and then they'd move outside the spot. Or their spouse would be filming them and not concentrating, and filming off randomly somewhere else. So we've dealt with all of those types of issues, and they're not deal breakers, but they just detract from the effectiveness of the system. Quite often difficulty hearing between the participant and the instructor. Sometimes the participant not hearing instructions coming through, or the clinician not hearing the feedback from participants. We've had a lot of administrative issues around processing telehealth appointments, and I won't go into a lot of detail about this. I think any time that we've changed our modality of exercise delivery, we've had some issues with our clerking processes, and especially when we had multimodal delivery, that became very complicated as well. We're sort of in an environment where our clerks were sort of changing quite regularly and often not on site with us. So yeah, the administrative issues were quite significant, and that's had an impact on ABF, activity-based funding, which our managers at the hospital are always mindful of. And we've had to explain what some of those complexities around the documentation of activity have been. We've also found that the DNA rate with telehealth and certainly phone call follow-up was much higher than our face-to-face appointments. So our DNA rate with face-to-face historically is around 20 to 25%. So we always overbook a little bit. But there are always going to be people who don't turn up for one reason or another. They're not well, or they turn up at the hospital and they can't find parking, so they go home. A multitude of reasons why people may not turn up and don't always let us know. But we found quite commonly with telehealth, where we'd arrange a time with a patient and they wouldn't log in at that time, and we'd give them a call to say, "Oh, you're joining the telehealth session," and they'd say, "Oh, no, sorry, I'm out doing my shopping," or something like that. So our DNA rate with telehealth was more like 35 to 40% compared to 20 to 25% with our usual care. Patient preferences, as we've discussed a little bit, some patients just didn't like it and didn't want to give it a go, or perceive they didn't like it. And also staff preferences. So that's something that's come up amongst our staff. I had one staff member who didn't resign, but was pretty much at that point and we had a conversation, and the staff member said, look, the thing I like about my job is dealing with people face to face, providing exercise face to face, helping people with their exercise prescription, but sitting on a computer hour after hour running sessions for people at home, I'm really not enjoying. And I don't think I can keep doing this for much longer. Thankfully, we are transitioning back to more of a business as usual approach at the moment. So, hopefully, that will address the issue for that staff member. But others, said the same thing. They much preferred the face-to-face delivery of exercise than sitting on a computer and delivering exercise or monitoring exercise remotely. Okay, so just to summarise, COVID-19 has impacted the delivery of in-person cardiac rehab, and it's really led us to think much more about how we can support patients at a distance using a telehealth approach, whereas there probably wasn't the same impetus for us to do that historically. So it's been really useful in developing some of those processes that we can continue to use. A major challenge for us was remotely delivered cardiac rehab has been effective functional evaluation. And I think we've developed something that's been useful, but it's probably still not as effective as what we could do in a face-to-face environment. So we explored a range of different forms of functional evaluation, but there still needs to be some refinement of those processes. Ultimately, I think we need to continue to work on how we can improve telehealth delivered cardiac rehab and exercise, because there will continue to be people that either choose not to come into face-to-face programs, or they can't because of reasons of access with where they live. So where to next? For us personally, we are transitioning back to business as usual, and we've started to ramp up our face-to-face exercise clinics over the last couple of weeks with a view to building back up to our normal rates of patients over the next month or so. Okay, and this has been supported by our infection prevention specialists here at the hospital. Certainly our feedback from our clinical referrers was that they felt that patients weren't doing as well with their exercise rehab, not being able to come into a gym environment. So we've got good support from both cardiology clinicians, but also infection prevention clinicians here to start ramping up, even though there is still a bit of COVID circulating. We still think that having multiple modes of delivery is the best way of supporting the needs and wants of all the patients that we see. But the challenge is running multimodal cardiac rehab delivery. Certainly cardiac rehab by telehealth remains an important option that we want to maintain for people who live in rural and remote communities, even just to get them kick-started with their exercise program. And then moving forward, having greater access to remote physiological monitoring, and there have been studies which have utilised remote physiological monitoring, is something that we'd like to investigate. But again, it needs to be considered in the context of cost versus benefit. Obviously we don't want patients to be out of pocket for getting physiological monitors, but there are increasingly apps available that can help support people in doing exercise remotely and giving some feedback to clinicians. So we plan to continue to explore alternative models of cardiac rehab to support the diverse patient populations that we deal with. Okay, that's all I have. So thank you very much for your attendance. I'm not sure if there are any questions that have come through, but I'm more than happy to answer any questions that anyone may have So please feel free to ask. And if anyone has a quick comment that they can make about their experiences with telehealth, I think that'd be really useful to hear as well.
Yes, thank you, Andrew. And yes, please post anything in the chat, any comments, any questions, really be great. I'm so pleased to hear all those challenges you've been through. It's great to know that you're moving back out of that challenging time, and that people will get that social engagement again, because it's that engagement for you as clinicians, but for them, that's where their motivation comes from, both from the other patients and from the staff. And yeah, so without that, yeah, we can understand why the cardiologists, etc., will be pleased to see people back. It's good. So Andrew, I know we have a busy group of clinicians, so yeah, I'm not seeing anything in the chat right now. So I'll thank you very much. As always, a fabulous presentation. And just
you
to
can
let
see my email on the screen, Helen, if anyone had a question that
yes.
that they wanted to raise with me, I'm more than happy for people to email me.
Absolutely. Andrew is always very kind with his time and expertise. So please get in touch with Andrew if you have something you wanted to discuss with him. That's great. And next time we have a long COVID session. It's not longer than the hour. It's about long COVID and some chronic care clinics which have commenced in Perth. So that's important. I know much is happening in the eastern states, but COVID was late to come to Perth. So it's interesting to hear about these new clinics springing up. And that'll be Katie Stewart, who's an exercise physiologist and the director and co-founder of Chronic Care Australia. So thanks as always for attending. Please fill in the evaluation because it allows us to know what other sessions you would like and how well we're doing, or if not. And thanks again, Andrew. Great session. And yeah, take care and stay safe, everyone. Bye.